Good day everyone, this is Senior Clerk Goldemir Israel, and in this video, I will be showing you how to perform an endotracheal intubation. We have a case of a COVID-19 positive patient to be intubated after the patient had difficulty in breathing, with the following vital signs. After donning complete PPE, we first assess the patient for a possibility of a difficult intubation. In doing this, we recall the mnemonic LEMON. L. Look externally for any facial deformities, tumors, goiters, short necks, or burns. E. Evaluate the 3-3-2 rule. Ask the patient to open his mouth, and it should be at least 3 finger breaths for the mouth opening, at least 3 finger breaths from the mentum to the hyoid bone, then 2 finger breaths from the hyoid bone to the thyroid cartilage. M is for the Malampati score. Ideally, the patient should be at your eye level, and ask the patient to open his mouth again and stick out his tongue. O is for obstruction. Check for any obstruction in the oral cavity or in the neck for any masses or hematomas. And lastly, N for neck mobility. Next is the preparation of materials. With this, we have 2 mnemonics, MAIDS and SALT PS. First, MAIDS. M for monitors. Prepare the cardiac monitor and the pulse oximeter. A for airways, which include the endotracheal tube, stylet, laryngoscope, bag valve mask, nasopharyngeal, oropharyngeal, and laryngeal mask airways. I for IV fluids. D for drugs. Since the patient is hypotensive, a neuromuscular blocker would suffice to relax the patient's muscles and to prevent hypotension. For this patient, we will be giving succinylcholine IV at 1.5 mg per kilogram. And lastly, S, suction catheter and machine. SALT PS. These materials should be by your bedside during intubation. S for suction catheter, A for airway, L for laryngoscope, T for tube. Choose the appropriate endotracheal tube for the patient. P for plaster to secure the endotracheal tube, and S for stethoscope to confirm placement. In positioning the patient, the sniffing position should be assumed. Put pillow under the head of the patient. With this position, you obtain a good line of vision since the oral, pharyngeal, and laryngeal axes are in line. Due to the COVID-19 pandemic, intubation of COVID-19 patients, such as our patient, may bring risk to the healthcare workers. Because of this, aerosol boxes were made to protect them from aerosolized droplets. For the basic airway procedures, first, suction the secretions or vomitus that may obstruct the patient's airway. Next, perform a chin lift and jaw thrust maneuver in order to displace the tongue inferiorly. Do this by tilting the patient's head back, pushing down on the forehead, and lifting the chin using the index and the middle fingers. Next, re-oxygenate the patient before intubation. This is important to allow the patient to have a reserve oxygen. A bag valve mask with an airtight seal is used, and an airtight seal is done by using the CE grip. Maintain a patent airway using either a nasopharyngeal airway, oropharyngeal airway, or a laryngeal mask airway. Ensure that you have the proper size for the patient. Also ensure that the patient is given succinylcholine prior to the insertion of these instruments. If the patient's O2 status is not improving, we proceed with the advanced airway. If the patient's time of previous ingestion is not known, perform Sellick's maneuver in order to prevent aspiration of gastric contents. Make sure to check the patency of the cuff by inflating the pilot balloon. Deflate once confirmed. Position the thumb and the index finger of the gloved right hand on the right mandibular and maxillary premolars. Fully open the mouth with scissored motion. Hold the laryngoscope with the left hand and insert the blade along the right corner of the mouth, sweeping the tongue to the left. Advance the laryngoscope towards the vallecula until the glottis opening is visualized. With a pencil grip, Insert the endotracheal tube at the right corner of the mouth and guide the tip towards the glottis opening. Advance the tube further by increments of 2 cm until the cuff is about 3 to 4 cm beyond the vocal cords. Once in position, remove the laryngoscope. In order to secure the tube within the trachea, inflate the cuff using 10 cc of air from the syringe. Once done, remove the stylet and attach the tube to the bag. Confirm the proper placement of the tube by auscultation. There must be equal breath sounds in both lung fields and absent gurgling sounds in the epigastrium. Also observe for equal chest rise. Lastly, anchor the endotracheal tube at the right side of the mouth using the plaster. So that's it for this video. Thanks for watching.